Hi everyone, it's Talysha and Jackson here again, and tonight we're talking musculoskeletal objective assessments, and we're just going to have a little bit of a chat about how both of us do our assessments, and there may be a little bit of differences, but hopefully the whole process just gives you a little bit of an idea on different approaches that you may take and how there's no one size fits all for this approach, and how you can actually use your subjective history taking to guide your objective history, not objective history, your objective assessment. It's been a long day. All right. Hey, Jackson.
How you doing? It's a good,
long day.
It's a good topic, I think. Keen to jump into it.
Yeah. So tell me. Oh, hey, Nico. Okay. So when we're talking objective assessments, in a nutshell, what would you describe that as?
Any assessments that you take as a practitioner, as opposed to what the client is or the patient is telling you. So information that they may not necessarily detect or know for themselves. So subjective is all from their point of view, whereas objective is from our point of view as a practitioner. That's my take on it anyway.
Yep, I agree with that. And so for you personally, where in the initial, well, it doesn't have to be the initial, but in the consultation process, where does the objective assessment fit in? So you've had the person come in, how can I help you? What are you here for today? When would you start doing some objective assessments?
Well, to be honest, the objective assessment stuff can start straight away. Like you can, for example, you can get a general feel for the way they move and function when they get up out of the chair in the waiting room, and also depending on the client, obviously, if they're elderly or injured or whatever, you can have a look at the way they move generally, and you can do a gait analysis on the way into the consult room before you even sit down and talk to them. So you're objectively looking and on alert for things all the time, I think, throughout the entire consult. Even more subtle things like if you look into their eyes when you first sort of meet them, and you're looking for sounds a bit deep and meaningful there, but if you look into their eyes and just get a feel for their sort of alertness. So they may be a more if we're talking about fight or flight sort of parasympathetic, sympathetic nervous system, they may be really agitated and really a bit hyped up on the way into the consult as well, and you can sense that their nerves and that sort of thing in the consult if they're someone, particularly people with chronic pain and that sort of thing. So those are all like objective assessments that you are doing all the time, right from when you first meet the person.
Yep.
Would you agree with that?
I definitely would. And it's quite interesting. And it's probably something that might be beneficial for even new or recent graduates. That there's even a little thing that I can't even remember who it was when we were at uni that they told us is a good approach. And I still do this to this day, is often I will follow the patient or the client into the room. So guide them in, watch them from behind. But yeah, even when they're sort of initially first getting up out of the chair in the waiting room, or if you're out in reception and you can see them walk in. Because one thing that it doesn't happen all the time, but some people, they can actually change how they're moving and how they're behaving when they're aware that they're on show. So how someone may walk through the car park versus how they may walk in the reception area versus how they'll actually be in the treatment room can be vastly different. Not all the time, but it can happen. And there's other things that you can look at, even just, how they get into a chair, get out of a chair, lots of little things that you may not pick. Like, say if you're doing, say, an assessment for an Achilles tendinopathy or something, or it's a specific movement, you may sort of focus in on one area and forget to look at the body as a whole. So observing just their overall movement pattern as early as you can without them being aware of it initially, because like I said, when they're on show, they can behave a little bit differently. So
Yeah.
that's probably one thing that I would recommend, but I agree with everything that you're saying. And then, so I know a couple of months ago you put together a biomechanical assessment template for people to work through, which I think it's fantastic for new graduates. But for all of your biomechanical or musculoskeletal assessments, do you follow that really comprehensive assessment guide that you used to use? Is that still something that's
Yeah.
a thing?
Yeah, it's a good question. So, as far as like a biomechanical assessment template, so like we get them at uni, and clinics may have their own forms to work through and that sort of thing, and that's great. So I found that really helpful for me as a new graduate, and I sort of made based on the stuff I learned at uni, and then based on the stuff that you taught me, I made my own sort of template, and you already had a template as well. So I sort of just adapted that, and following that through from start to finish, and doing all of those measures and writing all the stuff down for every single client that came in. That was really, really helpful for me as a new graduate, because it got me that repeated exposure to the assessments, and got me really familiar with just general anatomy, and the different responses to different tests in a whole range of different people over and over and over again for like 12 months or whatever. But then as you start to develop your skills, you start to realize that that's a little bit tedious, and I was sort of got more and more away from the template. And nowadays, I'm more just only write things down that I find to be significant. So you don't have to write down, for every single joint and every single muscle. You don't have to write, within normal limits, or you don't have to write, you know, how many degrees it was. I tend to only write down things that I find are really significant. And yeah, you can definitely, as you get more experience, I feel as though you can tailor your assessments a lot more to the individual, and you don't have to go through everything, because going through everything does take up a lot of time. I got really good at it. I was able to get through the full form in the initial consult, but yeah, definitely I don't follow any templates per se anymore.
Yeah.
Yeah.
And one thing, would you, because I know I really did ram this down your throat when you worked with me in Foster, that if you have multiple practitioners working in the same clinic, do you think it's more important to have a little bit more detail just in case you're not the practitioner seeing that person? So if there is the likelihood that you'll be sharing that person between multiple practitioners, would you possibly change your approach to how much you document when it comes to an assessment?
Yeah, definitely. I think yeah, it's a bit of a balancing act there. So you obviously you want to provide, or you should always provide enough information in your clinical notes, and in your assessment. You should do enough tests and record enough stuff down so that someone else could come in and understand what they need to do to pick up where you left off. Definitely, but yeah, it's just a balancing act. Yeah, I write down all the relevant information nowadays that will be helpful to me and helpful to Daniel, the other podiatrist, who if he sees one of my clients. So yeah, and we're on the same page as well with all of our assessments and stuff. So yeah, we generally tend to understand each other's notes right well. But yeah, I think that's a good point. Yeah, writing down as much as you need to, but also keeping it simple for yourself as well, and also simple for the patient. I think if you are just doing so many tests, you need to also explain why you're doing certain tests and that sort of thing. So, but we can go into that a little bit more as well. But
Yep.
yeah.
And David has just asked a question, which basically a huge chunk of this live stream is going to be about. And David's asked, does templates impact on patient-centered care, e.g. not following a recipe?
Yeah.
And that's the next area that we're going to be chatting about. And this is where, like for me personally, and I know you do it as well, where the subjective history and that entire initial process, getting to know the person, how that dictates essentially what you would be assessing objectively. So what we mean by that is, and like I know Jackson does this because one, I used to work with him, and two, we talk a little bit when we're not live. So essentially, if you've got someone with a certain pathology or a certain movement goal and they've told you particular things during your initial consultation, that, yeah, will help guide you with, okay, so if there's someone who, say they're an 80-year-old lawn bowler, you're not going to need to do a single leg hop test to assess their Achilles tendinopathy because A, it may not be in their physical capacity anyway. B, it's not part of their overall movement goals. They're not looking to get back to movements that require plyometric loading of the musculo-tendon unit.
Mm-hmm.
So using that history and looking at the person that you're treating, you won't need to follow that objective assessment in the case of an Achilles tendon pathology. So would you agree with that?
Yeah, definitely. And I definitely use the subjective history to guide I combine it with my initial objective test to guide the rest of my objective assessment. So rather than just going through absolutely everything with everyone, because that's not realistic, I feel as though if you combine so if you get a really good idea of what's going on, if you use your subjective history taking really, if you do that really well, like what we spoke about last time, and then you can get a bit of an idea of exactly what's going on and what needs to be done based on what they've told you. If you've asked enough questions and the right questions and you've got some good answers out of them, then you can sort of try to correlate their symptoms and their what they're describing and what you think the condition is to the way that they're moving and the way they're functioning. So then you dive into your gait analysis and your more functional assessments. And everyone's got a different approach. So I was challenged by someone on this on LinkedIn, Ian Linane, who does a lot of
Yeah, no, Ian.
Yeah, Ian's a good bloke, and he prefers to do his non-weight bearing stuff straight away. He prefers to do that first before gait analysis, and that's fine. So everyone has a slightly different way of doing things as long as you can justify it. And my justification for doing gait analysis and more functional assessments first is that I feel as though if you combine that, their subjective history taking, that what they've told you, with your functional assessment, the way they move overall throughout the day or throughout their task that they're experiencing pain with, then that gives you a pretty good idea of what further testing needs to be done. Whereas if you dive into all the further testing first and do all the non-weight bearing stuff, sometimes you can find things that may or may not be significant, and you can find a joint might be slightly restricted compared to the other side, for example. And if that's the first thing that you find, particularly as a new grad, you start to wonder whether or not that's significant. It may lead you astray as to getting to the bottom of what the actual problem is.
Yeah, that's a good point. And I think there's a few things that will factor into that. So, yeah, who the person is sitting in front of you, even just how your clinic is set up. So one of the last clinics I worked at, the treadmill and the gym and everything was upstairs. So it just made the flow a lot better, doing a lot of the non-weight bearing and what functional tests we could do in the clinic room and then take them upstairs, because that was just how it flowed with that, instead of being downstairs, upstairs, downstairs, back upstairs. It just didn't work too well. But then, like we were touching on, what's really good so if you're using your subjective history to guide the objective assessment, it can sort of give you an idea of sort of where your starting point for your assessment may be. So if you've got someone coming in with, I use the example of Achilles tendinopathy just before, but it could be Achilles tendinopathy or plantar heel pain. And even just the initial observation of how they're moving and getting into the treatment room. Do they have a really severe antalgic gait? Are they avoiding loading the area? A few things like that. And then getting their history of sort of how bad is the pain, when are you experiencing the pain, and going through everything like this. If they're saying, oh, the pain's not too severe when I first get up in the morning, it's only if I've been running for 5 or 10 kilometres, you may not need to, in the case of plantar heel pain, do the non-weight bearing windlass test and like what I like to call the modified Royal London Hospital test. And the same with the Achilles tendon. If they're not getting really high levels of pain and there's sort of no discomfort walking uphill. It's only after they've been relatively active on that area that they get the pain. You may not need to do the dorsiflexion lunge test to see if there's compression at the insertion. You may still do that test for range of movement assessment, but you may skip some of the sort of less intense assessments and move on to the ones that are probably a little bit more provocative. I think as a new grad or a recent graduate, or even if you're someone that's been practicing for a very long time and assessing musculoskeletal conditions are relatively new to you and you have the time, I would probably go through a little bit more in depth or through all the stages of the assessment, just so you can get a little bit familiar with how everyone does it, and even just learning how to explain the tests. So it's practice makes perfect, really. But yeah, essentially you'll be using this, and like in the case of Achilles tendinopathy and plantar heel pain, a lot of the time what they tell you subjectively, like we were discussing, I think last time with the subjective history, is a lot of the time, even when you're doing these assessments via telehealth and what the literature supports are the accurate diagnostics, you don't actually need to test and physically touch the patient. The information they give you is typically enough to perform your diagnostics, and then you'll use the diagnostics, the objective assessment to sort of, confirm and move forward from there. Does that kind of make sense?
Yeah, definitely. I think it's very contextual as well. So that's just
I just saw your comment.
That's was that a comment that you want to answer?
Yeah, literally what I was just rambling on about. I just looked onto the other monitor and saw Dean's comment.
That's I think it's very, so what you actually do in your objective assessment is very contextual as well. So what I'm talking about, where I prefer to take a really good subjective history and then dive into gait analysis and functional tasks such as squatting, lunging, step ups, calf raises, that sort of thing, and then do my non-weight bearing stuff. That's for at one of the clinics I work at Proactive. We have a high client load of like chronic pain clients. So there's less sort of acute stuff there. So obviously if someone comes in with an ankle sprain or an obviously really flared up, plantar fasciitis or an acute injury or a plantar plate tear or stuff like that, that is acute, then you're not going to be able to put them through all the functional tasks. Or you may prefer to, it's probably more important actually to do the sort of pathological test to find out what structures and that are actually injured and what we need to do about them at that point in time. So I think it's very contextual to the client, and then also to the other thing you mentioned before about the setup of the clinic. That's not something I had thought about before. So that's a really good point.
And that's just from my experience working in lots of different clinical settings. So, as you know, at Foster, that was a relatively small room. So if we were going to do a gym assessment, I'd have to take them down to the gym that we ran that out of. But then at the last clinic I was at, the gym was upstairs. Clinic before that, the gym was down the corridor. That was relatively easy. And then there's some areas where you don't have access to a gym or anything at all, so you do have to get a little bit creative with that. And there was one clinic where it would just be us out the back of the clinic running up and down the footpath if we were doing an assessment. So there's lots of different things, to cover. But I think the main message for people to take away from a lot of this is there's no sort of fixed recipe as far as what you need to assess. And like you sort of mentioned, we can end up over assessing a little bit. But like I said, it's when you're first starting out with it, even just to practice the tests and get exposed to as many feet and legs and limbs as possible, just to get an idea of how to do it, how to explain the test, just to build up your practice in that sense. And then over time, you will start to learn, okay, when someone comes in and they've reported that they've got X, Y, Z and their goal movement is ABC, then you may do the single leg hop test or the triple hop test or lateral shuffle tests or anything like that, to guide where you're needing to go.
Yeah, definitely. With the, like, say, more biomechanical tests, so your typical podiatric biomechanical testing, a lot of the non-weight bearing stuff. I mean, I'm learning more about it all the time and reading more on it. So you might be able to have a bit more of an idea than me. But the a lot of the results of those tests don't correlate into functional or into dynamic um, testing. So the static testing that you do doesn't predict dynamic function with a lot of those traditional tests.
No, it doesn't. And there's, very little evidence that says that it does. Basically, it doesn't.
So it makes more sense for me then in that scenario. Obviously, contextual again, but that's why I prefer to do the more functional task first, because that gives you a better overall idea of how the person is moving and functioning, and their strength and their capacity to do stuff, which is what we're trying to get them back to doing, is to doing stuff. So it makes more sense to me to do the functional task first. But I always still do your static assessment. So I obviously just have a general feel of the person's foot through all the joints, check for mobility and that sort of stuff. But yeah, just after the functional stuff.
Yeah, I do find that, because a lot of the time with the non-weight bearing tests that you do for the foot, you can run through a lot of that within a matter of seconds. Even first MTPJ, dorsiflexion, plantarflexion, first ray, second, third, fourth, fifth ray, mid-tarsal joint, subtalar joint. You can run through all of that in, almost no time at all. And then again, if you've had exposure to quite a lot of feet, that after a few years you will have, then basically you may highlight one thing in that really quick bang, 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 that, I'll have a little bit more of a look at that in depth. But if overall it just feels like it's relatively normal and it's not fitting in with anything that they're telling you, I do agree that you don't have to record everything down. It's because if you've got 10,000 measures that are all within normal limits and it's not correlated in any way, shape or form to what they've reported or what it looks like is going on, it's probably not really relevant to include it in the notes or the assessment notes, I think.
And back onto the template as well. So the question before was about the template not really being individualized care sort of thing. So I think the templates are still really good to have, particularly as a new grad. And then they form sort of a framework, so you don't have to always stick to them if you've got some sort of system or some sort of preferred way that you do things, but it's just a framework, so you don't have to follow the template.
Yep.
But I think it's good to have systems and frameworks in place, but definitely no recipes. Recipes are different to a framework.
Yeah, I agree completely. And that's like, even with the exercise therapies course that, the module that hasn't come out yet, it will happen very soon. I was up at 4:00 this morning working on it. And that's like exercise therapies. There's no recipe or one size fits all approach with it. But if you've got the framework and the concepts for it, then you use that framework and basically the systems around that to individualize that. And I do think it is the same with the objective assessments.
Yeah, for sure. And probably another topic for us to discuss, and this could probably be a whole another video in itself, is gait analysis. So gait analysis is obviously part of the objective assessment. So do you want to briefly touch on how we both approach our gait analysis in general? So you don't have to go too detailed, but just the general approach to it, how we do it and what we're looking for, sort of thing.
We might have to do a whole nother video because my brain I've been up since 4:00 this morning, so I'm a bit tired. It will depend on what the presenting complaint is for me, and also B, what their overall movement goal is. So if it's someone that, I will do a general walking assessment anyway, and that's even if it's just watching them walk into the clinic room. But I'm not going to do a running assessment on someone who isn't ready to run or doesn't want to run, and that's not going to be part of their life unless they're being chased by a bear. So there's no point doing a running assessment there. But typically when I do a gait analysis, I tend to start big and then hone in. So I don't, as soon as I start observing someone, it's not, oh, how much are you pronating? It's looking at that entire body as a whole. So just head to toe. So I usually start from the head and work my way down. So you're even just looking for arm swing and everything like that, hip movement, hip rotation, hip drop. Then watching them from the side, and this is more so when it comes into a running gait assessment, foot placement in relation to the knee and the hip, how far, the tibial inclination, that's the word I'm after. And then when you're observing them run, how much is sort of backside mechanics versus front side mechanics. So like I said, I typically start big, look at everything globally, and then sort of hone in on one area and basically link it together. So if you are noticing that there's like an abduction or a heel flick, and you just observe that globally, and then it'll be kind of honing in on, okay, having a look at the hip, is there something happening there? Does it happen more so when the foot's twisting off the ground? Is it an abductory twist where it's coming from?
Yeah, we could it does. We can definitely break down the gait analysis and do a whole nother talk on that.
Yeah, I do have quite a few really good papers on running assessment and gait assessment. So people can throw down in the comments how keen they are for that. We've got quite a few talks lined up, not just with Jackson and I. So we've got Maddie Spicer from New Balance, who's really keen to have a chat. They've got some really nice tech coming into their shoes, and I was catching up with him a few weeks ago. We've got Ben from Solution, which Jackson and I mentioned the Solution a little while ago. So Ben's going to come on and have a chat, and there's a few other people that have reached out on LinkedIn. Some is more on gait analysis as well. What else do we have?
Also in the objective assessment is your diagnostic testing as well. So like if someone comes in with an ankle sprain, all that testing on the ankle, that's your objective stuff too. So, Achilles, ankles, heel pain assessments, all that stuff, they can all be topics of further discussion.
Yeah, well, the whole ankle assessment, that one's really quite interesting, because when you're doing an acute ankle assessment, you do have a little bit of a window where the tests aren't really valid. So you've got within a few hours, I think it's a few hours of doing your initial ankle sprain, where the tests will be relatively valid as far as anterior draw and a few other ones. But then once we've got a little bit more bleeding and a hematoma forms and we're in that inflammatory phase, I think it's 2 or 3 days where the tests, they become really invalid. They won't give you a correct measure. And then I think it's 4 or 5 days post-injury, once the inflammation starts to settle, that's when the tests can become valid again.
Yeah,
well, we can go through the ankle assessment one. That's one of my baby areas I love. Yeah,
that makes a lot of sense, because you're going to be, you're just going to have a sore as hell ankle after you sprain your ankle. So a lot of the testing, if you're looking for pain and that sort of thing, it's going to be everywhere.
And even just with the anterior draw, you won't get an idea of if there's much ligament laxity, because there's just that much swelling in the area. So there may be, but you can't. It'll possibly give you a false positive or false negative.
Yep. No, definitely agree with that.
Okay, so tonight we've been trying to keep the videos to less than 40 minutes, just one, people's attention spans, and two, with how long it takes to edit. But so essentially with the objective assessments, it's that one, if we could summarize it, it would be there's no one size fits all solution for it. And as Dean sort of commented on and we were saying, the objective assessments are only there to confirm the subjective history, and you can use you should use the subjective history to guide what actual objective assessments that you're going to do. So it'll be based on their presenting complaint, the history that you take, what their goal movements and activities are going to be, and where you think they're at relative to their injury at that point in time. That would be what helps you select what tests you do during that specific consultation.
Yeah, definitely. I agree with that. Good
And
summary.